There we go. Woohoo! Thank you. Okay, so for there we go. For farm this week, the meds to know list is updated, so you have the link there. I reformatted it so it goes by weeks, which I think you knew. And so for the week 6 meds, we're going to focus on midazolam. Let's do midazolam. Because you're going to see that one. You need to know malignant hyperthermia, which we're going to talk about. And then also in the lesson gives you another list of the things that you need to know. There's also a 5-point quiz on the corticosteroids and the NSAIDs. And I also have those areas for you, what you need to know there. And then remember, week 7 and 8, we don't have class, so you can get a jump ahead on week 9, which is the antiplatelets, anti-coags. So you have that available to you. And so basically what you guys did in your case study, right, is the balanced anesthesia, right? And you guys did a really nice job. Those that I've looked at so far, you did a really nice job with that. And understanding that in addition to the main anesthesias, there's also balanced anesthesia, which lets us combine anesthesia, right? So what are you guys seeing like in OB? What kind of medication are they giving or mixing together?
Epidural?
Yeah, for an epidural. Mm-hmm. And so they'll put like people just they'll put like fentanyl, and then they can add something else in there. Sometimes they'll do bupivacaine, which is lidocaine. So anything with a cane, like you go to the dentist, right? And they do lidocaine. They give you injections, right? That's a local anesthetic, right? And so that's basically the things that you need to know. You don't need to know all of these. It's lower on the page what you need to know exactly. You already know we're going to cover antiemetics some more, but you know what an antiemetic is. You know the cholinergic blockers are going to stop the secretions, right? So you know those. And in the key points that you did for the farm, these are the meds that you were given, right? So you know these already. Case study you're doing. Let me show you. Here we go. So for the 5-point quiz, again, this is all on that overview lesson page in farm. Prednisone, right? What classification is prednisone?
Corticosteroid.
Corticosteroid. What do corticosteroids do?
Reduce inflammation.
And what's some of the things that happen when you take a corticosteroid? What happens to the immune system?
Suppressed.
What happens to glucose? Glucose regulation.
There's increased sugar levels.
Yeah, that's what you need to know, right? Because those are like the main key things with corticosteroids, for which prednisone is the prototype. Does that make sense? Yeah. And then same thing, like what does ibuprofen do? What's the difference between ibuprofen and acetaminophen?
Ibuprofen reduces inflammation, and acetaminophen is an antipyretic only.
Yeah.
Pain reliever.
Yeah, exactly. And so that's a good thing to know. What about aspirin? So ASA, excuse me, is acetylsalicylic acid, which is aspirin. Does everybody get aspirin?
No.
No, not anymore, right? Especially not kids, right? And so, but what do we use aspirin for? What clients do get aspirin?
Anticoagulant.
Yeah, it's not technically a anticoagulant. It's a what?
Heart failure or post?
Yeah, You might, it's more, it's a blood thinner more, it's not like a, like it's antiplatelet kind of type thing. And so, it's gonna keep the blood thinner and keep the platelets from clumping up on each other, which is gonna block the circulation, block your perfusion. And then, ketorolac, have you seen ketorolac?
Yes.
Yes, and what's the other name for ketorolac?
Toradol.
Toradol, right? And so we usually give that IV. What classification is it?
NSAID.
Yeah, look at, you guys can teach the class. You know this. It's good, right? And then celecoxib is another one, another anti-inflammatory, non-steroidal anti-inflammatory. Because see, they're all under that NSAID category, right? And so there's 10 questions. They all have to do with those 5 topics, and they're all worth half a point each for the 5 points. It'll open on Thursday, it'll close on Saturday, and you get 2 attempts. You won't see the answers, but you get 2 attempts. Does that make sense? And you get 20 minutes for it still. Yes, no.
Yes,
Yes,
Makes
thank you.
sense? Yeah, okay, so 20 minutes, and then on top of that, you get 2 attempts. Cool. The other one that you're gonna, the other thing that you're gonna have is the, there is an anesthesia escape room that you'll have. And this is the kind of one that some students don't really like. But let me find, I can show you a preview just because. Maybe I can, or maybe not. Come back. And it won't open until Thursday. So if you're trying to get to it, you wouldn't be able to get to it yet. And so it will open up. This will be the escape room quiz. You look around for clues. You click on this, go to the operating room, and then it will open up for you a picture of an operating room. And as you click around the room, and you can actually kind of see the cursor will sort of change shapes, so you kind of know where to go. There's 8 clues. You click on something, it will pull up a clue for you. It's a multiple choice question. So, but you have to look, is it question 1, 2, 3, 4, 5? Which question is, and write on your note paper. Okay, question 5. And then you're gonna write the answer down, because when you're done, then you click on this lock and key, and this will take you to the Google Doc. And that's where you're gonna write in your name and then write in the answers for the question. Does that make sense?
Yeah.
Yeah. And so you kind of have to look right. If you forget, you can click on the Bitmoji, and it just gives you the directions again. You may end up with multiple operating room windows open, and that's okay. It doesn't matter. Or you can click on the go back to the operating room, and it should take you right back there. If you have trouble accessing it, message me so that I can try and fix it in the moment. But from what I've tested, everything should work. So 8 questions, there's no time limit. And then there's the Google Doc, and it's worth 10 points. I just want
If
to,
you get a question wrong, will it let you out of the escape room, or does it keep having you retry?
it will have you keep retry.
Okay, perfect. Thank you.
That one out, close that one out, but it won't open until Thursday. Uh-oh. Not the one I wanted. A second. Let me do this again. Ooh, we grew. And I want to just make sure that I go over the key points for that as well, so you know what to focus on. So let me go back to farm. I closed too many windows. Okay, there we go. So the escape room will focus at the bottom here. So we went over the NSAIDs. These supplemental PowerPoints are pretty good. I like them. I also did post them a question one, But what you need to know, these are based off of the objectives, is, you know, what are medications, pre-op medications that are going to reduce anxiety, right? What classification are those? Like lorazepam, right? That's going to midazolam. Those things are going to reduce anxiety. What kind of medications are going to reduce secretions, right? We just talked about that, right? The anticholinergics. So a lot of these hopefully are things that you're going to be seeing over and over again. You know, what about opioids, right? When we combine things, we don't need as much of each of them in order to get the same effect. So when you talk about local or regional anesthetics, I think in terms of local, like we think, oh, that's the lidocaine that we get the injection, or like a topical that we can put on our hand or something like that. But understand that a regional or local anesthetic is also an epidural or a spinal. Why is that?
It only blocks the nerves on certain parts of your body.
Yeah. And so that, I think we tend to forget sometimes that that's also what a local or regional anesthetic is, because it's just taking care of one area. And so the epidural goes into the epidural space, and then the spinal goes into the, what is it, the arachnoid in the spinal column, right? We're into the CSF, the cerebrospinal fluid. And that's why the client can get a spinal headache. Right? Because if we stuck something in like a lumbar puncture, when you stick the needle in and you pull out the cerebrospinal fluid, if the hole doesn't close up and fluid's leaking out, you can get a spinal headache. And so one of the things that we do for that is you lay the person flat. We don't want them sitting up. We want them flat. No Trendelenburg if Jordan's here. We want them flat. And then a lot of times what they'll do is called a blood patch, which is where they actually take some cells to cover over the hole that was left in the spinal, in the dura mater, for the spinal column, and then you also put it over the skin as well. So if you ever see that, it's kind of cool. But I just wanted to bring to your attention that locals or regionals aren't just injections or topicals. It can also be, there's a caudal block, which is at the end of the caudal part of in your tailbone. Basically, there's a specific place, it's in the PowerPoint, where they can place the anesthesia. We do that a lot for kids because it's easier to find and works pretty well. And then you might have heard, I think we talked about or read somewhere, something called a saddle block. So a saddle block is it's also an epidural, but it's the part of, if you sit on a saddle on a horse, it's those areas that would be numb. So the inner thighs, the part where you're sitting, your butt, that's like the saddle piece of it. So there's different kinds. I'm not so much worried about those particular ones, because the ones you're going to see are pretty much going to be the epidural and the spinal. You might also see general anesthetics. And so that's a lot of times where you'll see balanced anesthesia as well. What do you know about malignant hyperthermia?
Is that an increased temperature
Mm-hmm.
due to anesthesia? And it's
Right.
a genetic condition.
Mm-hmm. It's a genetic condition. So I had you guys in 56 doing that that pre-op checklist, right? Because that's one of the places that the nurse is going to hear about that. The family's going to say something like, oh yeah, my grandma had trouble with anesthesia. And so then you're going to say, well, what kind of trouble? Can you tell me about that? Or, oh yeah, my dad used to get this really bad rash or had trouble with surgeries, right? And that's a clue to you that, okay, this person we need to be on the lookout for that. And you want to do cooling. You guys had this in your case study, right? So it tells you, I think they were on the succinylcholine. And so you stop the medication, you do some cooling measures, you may be doing the dantrolene, depending on the order that the physician wants you to go in or what the client looks like. And then, so moderate or conscious sedation, you're still awake, but you have that amnesia component. Ketamine's one of the medications for that. And then different post-op medications like anti-nausea, pain medications, or antibiotics sometimes. And then the paralytics like the pancuronium. So those are, they call them neuromuscular junction blockers, because actually what they're going to do is is paralyze the client. So what are some reasons that you'd actually want a client paralyzed? That sounds kind of counterintuitive.
So intubate.
To intubate, maybe? I'm at Denny's. Starbucks was not close enough. What else? What else would why else would a person need to be intubated, maybe, or paralyzed?
Like for a spinal surgery, so they don't.
Maybe. And so sometimes another thing would be for kids what's called ECMO, or like a bypass, where you're on a bypass machine. And so you don't want the person moving because you've got all these lines going in the veins, and you don't want them to move, because if that comes out, they're going to die, because their blood they're on a bypass. The machines are doing the work for them so their body can rest. So that would be another reason for that. But there's some adverse effects that you might get, but because you're paralyzed as well. And so those are just some things to know. I don't think I've seen too many side effects from that. I think the main thing for that is like the client education, so they know that that this is what's going to happen, right? So they're not surprised that they're paralyzed. And also for the family, because the family won't understand it unless you tell them. They're not going to see their family member moving, and that can be really scary for them. But these PowerPoints do a really good job of talking to you about those things. Depression. Chapter 18 is just the anesthetic part. So Iggy, which I told you, they just have 1 chapter now instead of 3 chapters. And you did the case study, which is great on balance anesthesia. Really good article on spinal versus epidural. And so let's move over to care of the surgical client, and then we can tie in the anesthesia piece. Does that sound okay? Any questions on the anesthesia piece, or for what you need to know for the quiz? Take that as a no, which is fine. So what I wanted to do for the objectives for week 6 is I wanted to give you some of the information in the objectives, right? So in terms of what are various types and purposes of surgery? Why do we do surgery, right? There's different types. What would like say you're talking about different risks, like there's major surgery and minor surgery. What would an example of minor surgery be? Minor surgery.
Something elective?
Potentially. But I'm
Like
thinking
a bunionectomy or something.
maybe
Yeah, like
something like that,
toenail.
or a tooth extraction, or something kind of that isn't going to have major, hopefully, sequelae and consequences to it, right? What would major surgery be?
A C-section.
I'm sorry, say again. C-section?
Yeah, C-section.
That'd be major. Double mastectomy, gallbladder removal. Those kind of things. Those are major. Those have major complications that could happen as a result of them. You have the urgency, like somebody was talking about elective surgery. What's elective surgery? Like a bunionectomy, right? I can do it whenever. It's not emergent. I have this bunion, this big growth kind of thingy on my toe, and so I want that taken care of. Now, that can also be minor surgery. It could be, but there are some people in OB who have elective C-sections. We call them also social C-sections. That's another thing, because they want it on a certain date, or there's a certain reason, or they're going on vacation and they want to have the baby before they go on vacation. I kid you not, before they go on vacation or a holiday or something. We get a lot of those at CHOMP. Not at, I don't know about the other hospitals, but at CHOMP we get that a lot. What's the difference between? Yes.
I had a question about kind of like, I guess like the social more surgeries. So I was talking to some of my friends the other day, and they were telling me about the husband stitch. Is that like a thing?
That sounds familiar. Can you describe that? And then I could tell you. 'Cause I can't
So
remember.
basically it's more for the husband when like after vaginal births, just like an extra stitch to make it a little tighter down there.
Oh, gotcha.
So would
um,
that like, because I don't know, we were having this conversation and I was thinking that that's more of like to the discretion of the doctor because like I can't see that being covered under like any sort of insurance.
Yeah, no, because that would be to me, that would be cosmetic. And I mean, I don't know. I can see why you would do it. It doesn't, it might close the opening, but going up through the vagina, it's not going to make that any smaller or tighter, right? Just the vaginal opening. But they would have to, I would say they would do that if they were doing like an episiotomy or if there was any tearing or anything. I mean, that'd be between the person and their physician if that was going to happen.
Got it.
Yeah. Urgent, emergent, like what's the difference between an urgent surgery and an emergency surgery?
Before we move on from that, I just building on what you were talking about, major surgery versus minor.
Yeah.
I know we talked about elective versus non-elective. So like these mummy makeovers, those are major surgeries, but they are elective.
They could be, yeah, they could be major surgeries, but they're usually elective.
So that's why it's like fine line. Yes, it's major, but it's elective. So
Yeah. Mhm.
Okay.
And then what about like urgent versus emergency? Can you give me a time frame? Is there a time frame difference between an urgent surgery and an emergent surgery?
So would an emergent be like it needs to be right now?
Mhm.
That versus
Mhm.
urgent, like we have like a little bit of time, like 1 to 2 days or something.
Yes, and I believe that's the exact definition in the book. Is that that's like an emergency C-section, right? Like we see D cells, late D cells, the baby's heart rate goes all the way down to 60 or something and stays there, and they get rushed to the back. That's emergency surgery. We have to do that. Somebody comes in, excuse me, with a gunshot wound to the chest. We're going to take them immediately to surgery. We can't wait on that, right? Urgent could be like an appendectomy. It might be they come in, we're doing a bunch of tests, but it's not like we have to do it right now, especially if it hasn't ruptured. If it's ruptured, then we might need to go right away. But there's different degrees of that. But that's why I always say, like, if you think something's not right, like go to the doctor, do something, because it could be something that you don't even know about that's going to require emergency surgery. And then there's just different types of other types of surgeries based on the purpose of the surgery. And so you have something like a biopsy, a diagnostic surgery, an ablation, an ablative surgery, which would be a removal. So there's uterine ablations where they remove the inner lining of the uterus. That's an example. Palliative. Now remember, palliative care is to help with pain, right? So we're going to relieve or reduce the pain or whatever the process is, disease process that's going on. Reconstructive is to restore function, right? So we're restoring function after we've had breast cancer breast removal, and then we're going to restore function and do reconstructive surgery. Transplantation is just that, transplantation. And then oh yeah, that'd be great, thank you. Oops, did I lose my internet, or can you still, hello?
I still hear
We
you.
can still hear
Okay,
you.
because it says there's like, I don't have Wi-Fi. Transplantation, and then constructive would be to restore the structure in a congenital anomaly, because we're not restoring because it wasn't there. So when we get to the cardiac congenital cardiac defects, thank you, the surgeries that they do for those are going to be constructive, because we're not restoring function, it was never there. Does that make sense?
So like if a baby was born with the, what is that, the lip?
Cleft lip or
You're
cleft palate.
Constructive?
Yeah.
So that'd be constructive, not I mean, I guess it's kind of, in a way, it's sort of both, because you are restoring function. But if it's a cleft lip, for example, where it's open, like it was never functioning correctly to begin with. So it's
Okay.
more of a constructive,
Constructive. Okay. Got
because
it.
we're fixing something.
Mhm.
Now, moving on, things that you need to understand, are factors that place somebody at risk for complications associated with surgery. It's all well and fine to say, oh yeah, I want to, get whatever type of elective surgery, or somebody that's going to have a baby, right? That's going for a C-section. But what are we seeing? What comorbidities are you seeing in some of these moms?
Obesity, diabetes.
Yeah, exactly. Hypertension, right? With the preeclampsia. So there's a list here, which is are the answers. But there's always a risk then, right? So if a person has diabetes and they have a C-section, what complication might they be at risk for?
Infection.
Infection. Why?
Because they don't heal as fast as somebody that doesn't have diabetes.
Right. Exactly. If there's a history of perfusion problems, if there's previous incidents of infection or sepsis, smoking, because there's not as good a healing with smoking. The older you are, there's more complications. Obesity, even malnutrition. So you think of the obese, the larger person, but also if you're malnourished, that can be a problem and lead to complications for surgery. And so some of the complications, no, we're going to look at when we get down there. Never mind. Now, does that mean we don't do the surgery? If you have diabetes and hypertension, do we not
outweigh the risk and the benefits?
You have to and that's not our decision as a nurse, right? That's the physician and the client's decision when the physician has them sign the consent, right? So they should be talking about all those things. And then it's up to the client to decide, okay, is it really worth it that I want to have this done? An accurate and complete preoperative assessment. Again, you're doing that in the electronic health record. There's a couple students that I've seen so far gone in and looked at, have done a nice job with that. But we need to know, what's the medical history? What's the surgical history? How did they handle anesthesia, right? It says here, previous reactions or family history of reactions to anesthesia. That's a big thing, right? Because I can't guarantee the anesthetist is going to ask that question when they come do their history, right? I need to know those things. What about glasses, dentures, prosthetic legs, anything that's a prosthetic, right? Allergies, all those things are in that pre-op assessment. And so you need to know what is included in a pre-op assessment. When you're looking at lab and clinical data, we talked actually a little bit about it today with Keith RN, but what things in CBC, for example, might affect the client's response to drugs or anesthesia, or just in general healing from a surgery?
Platelets.
Wait, hold on, I got a platelets.
White blood count.
Hemoglobin.
Hemoglobin. Hematocrit. Right, I mean, those are the big things, right? If the client has really low hemoglobin and hematocrit, then we need to do something. It may not be, I need to make sure that the doctor knows, hey, these are the pre-op labs. This is what I'm seeing. Did you know this? Were you aware of this? Right? What about the BMP, the basic metabolic panel, is the one that's going to have all the electrolytes and the BUN creatinine. What are we worried about there?
Kidneys.
We're worried about the kidneys, and how are we going to know what the kidney function is?
Creatinine level.
In the BUN.
Just said creatinine is the most accurate.
And creatinine is the most accurate, because BUN can be affected by hydration status as well as kidney status, but creatinine is really more the kidneys, how the kidneys are functioning. right? And so that's what we're looking at as well. What, if the kidneys are not functioning well, what does that mean? I mean, what's gonna happen? How are things going to be affected in terms of surgery?
The medication, the anesthesia might linger.
Yeah, right? It's not gonna get cleared out of the body as quickly because the kidneys aren't filtering. And then what like, and the thing I think is really cool, you may not think so because it's 9:20 at night, but is that we talked about this today in terms of heart failure, right? And we're talking about care of the surgical client right now, but it's the same thing. It's those same important things that we're still looking at. The kidney function. Is there, signs of infection? Is there enough blood perfusing, enough red blood cells and oxygen, right? We're still looking at those things. What about electrolytes? What are we going to want to let the doctor know about electrolytes when we get the labs back?
Potassium, if it's abnormal, sodium.
Mhm. And I think Keith said it today too. Potassium is like a big one because of how it affects the heart. And so even if our electrolytes are not in balance, and that all has to go back to kidney function as well, then you've got drugs, the medications, anesthesia can all be, the effects of that can be affected. Does that make sense? So that'd be another good thing. That'd be another good thing to know about what we just talked about. Okay, and then when we're talking about complications, all right, because as the nurse, our job is probably either going to be in pre-op, in terms of getting the client prepared. So we're going to do the pre-op history, we're going to insert an IV, we may have a Foley, make sure everybody comes in, all the paperwork, the consents are on the chart, all those kind of things, right? And also education, right? What is going to happen? And when you wake up, then you're going to be in a different part with a different nurse, and this is what they're going to do, that kind of thing. They don't really talk at all about intraoperative nursing because that's a very, very specialized area. Anybody that's been in a C-section or that will be in a C-section, that's a good example of the communication and the sterile fields and all that. The other thing where nurses are, we're in the post-anesthesia care unit, we're post-op. I would never in a million years want to be a post-op nurse, mostly because it terrifies me, because I don't know, like, what am I looking for? Like, I can do an appendectomy with a kid, that's fine, but like PACU terrifies me because to me, there's so many things that could potentially go wrong that I'm afraid I would miss something. Does that make sense? And so even what Keith was saying today, like, what does your patient look like? What little things are going to be these big red flags? So different things that can happen and the interventions that you would perform, right? So taking gas exchange, right? What medications are going to potentially have the person have respiratory depression?
Opioids.
Right, and so there also might be, there could be an obstruction somewhere that we don't know about. There could be atelectasis, where the lung kind of collapses on itself. And so these are my little abbreviations here. So what's one of the big things that we teach them how to do pre-op? Incentive spirometry, right? To help expand the lungs, right? Increase the head of bed up. TCDB is my way of saying turn, cough, deep breathe. So that used to be a thing that we did all the time. Now it's more of having people cough to get any secretions up. And what do you do if you've had surgery and you don't want to tear the stitches?
Splint.
You splint. Can you explain that, Maria?
So when you cough, when they cough, you tell the client to use a pillow to place it over the surgical area so that they don't, their wound doesn't dehisce.
Dehisce. And we're going to talk about dehiscence and evisceration here in a second. So you'll even see for heart surgeries, they actually get a heart-shaped pillow, right? And it has like a little face on it. And so that's what they can use to put up against their chest where that incision is if they have to cough. And they might need oxygen, right? And assessments and, checking O2 sats, focused respiratory assessments, those types of things. Elimination, what happens as a result of anesthesia? What happens to urinary output?
Decreased.
Rose, was that you too? I'm trying to see who's talking here.
Yeah.
What's a paralytic ileus? Something's paralyzed. Something's not.
The intestines are paralyzed.
Yeah, is that Maria Lopez?
Yes.
Sounds like Maria Lopez. There we go. Because I can't see you right now. I'm just trying to listen. Paralytic ileus, right? Because that's what happens with the anesthesia is that you get urinary retention, your intestines don't move. You haven't had anything to eat usually because you've been NPO. But what happens if nothing's moving in our stomach?
There's no peristalsis, so
Yeah,
your bowels, everything stopped. That's not good.
yeah, that's not good. And so you can get infections, you can get bowel obstructions as a result of that. And so some of the things you're going to do is monitoring your intake and output, right? You want to have at least that 30 ml per hour, output. And I love that what Keith said today is that that's like a red flag, especially if you gave a diuretic, right? You need, and most of these clients will be on IVs post-op, so they should be putting out more than 30 mLs per hour. You might have to catheterize them. You might have to do the bladder scans. We're also checking for flatus because I've asked a couple of students that. What else are we looking for? And like a bowel movement. Yeah, but what if they haven't had a bowel movement? Gas. Are they at least passing gas? Because sometimes they'll let the post-surgical patient go home if they're passing gas, even if they haven't had a bowel movement. Okay, fluid and electrolytes. For fluid intake, post-op bleeding, right? What signs and symptoms are going to tell you that there might be blood loss?
Excessive bleeding, but if you're talking about like the vital signs, we talked about the increase of more than 10 in the heart rate. That has no other explanation.
And what other vital signs somebody other than Maria are? No offense, Maria.
Blood pressure would drop.
Blood pressure would drop, right? So see how even these things in perfusion, right, carry over to these other places. And there could be bleeding that in a site totally different than where they operated, and we just don't know it. Could be wound drainage, right? Sometimes in the PowerPoint, there's different types of drains. There's a Penrose drain, which just kind of looks like surgical tubing just kind of sticking out of the incision. There's also something called a Jackson Pratt, which looks like a little squeeze bottle. Those things can fill up pretty quickly. So anything that's going to lead to loss of fluids. So you're going to assess fluid status. You're going to check your IV fluids, I's and O's. You're going to look at the Rita and COPA like we talked about in skills, right? How much we talk about saturating the pad, right? Postpartum, right? But even after surgery, what does that C-section incision look like, or the hip incision, right? So the other thing to know is that when you're checking those dressings, what happens to the blood? Say it's not on the top of the person, say maybe it's on the side. Where does the blood go? Where do you have to look?
Towards the back of the client?
Which would be where? You're correct.
Posterior.
Yes. So not just their posterior. What is their posterior lying on?
The bed.
The bed. Yes, Arthur. So I can look at the dressing.
The perineum?
Well, it could be the perineum. I'm thinking of like if it's a hip or something other than obstetrical surgery, like a hip, for example. When I look at that dressing, there may be some blood, but if I turn that client to their side, I could have a whole pool of blood there that I didn't even know I had. And that will also happen in the perineum, Maria. I actually had that happen last year where like the student, I just kind of were watching this blood and I'm finally like, excuse me, nurse, right? And the woman went to go sit up and there was just like this pool of blood under her butt that nobody had really seen. So that's a suggestion, is always look under the client as well. Cognition, right? Safety measures, what are we going to do?
Socks.
To see if the patient is alert and oriented times 4.
Non-skid socks. What other things can we tell them?
Well,
Use the call light.
Use a call light, yeah. All those, and it seems like such basic, just like such basic kind of things. But I think that's what sometimes we forget is sometimes those basic things, those vital signs, checking LOC, making sure they use the call light. Those are very important things. When we talk about perfusion, remember I don't know if you remember, but we did talk about DVT in first semester, right? And we talked about what the sequential compression devices, the compression stockings, right? Those kind of things, because is the person very mobile after surgery?
No.
And so we're worried about that, right? So you're gonna have your SCDs. What about infection or tissue integrity? You already told me sometimes the site can be infected. What's the difference between dehiscence and evisceration?
Dehiscence is when there's spontaneous opening and then incision wound.
Okay.
And evisceration is when something's protruding out of it, such as an organ.
Yeah, so I like to think of evisceration like viscera being your insides, your guts, your intestines, and E being out. So if I know that evisceration, that's guts coming out or some body part coming out because that incision has split and an internal organ is coming out. The dehiscence is when the incision starts to come apart, and that's also a problem. What risk factors place a client at risk for dehiscence or evisceration?
Coughing.
Oxygenation problems.
What else? This
Elderly
list.
people.
Malnutrition, lack of protein.
Yes.
What you said,
Or
like
wound
coughing
healing.
maybe.
Obesity. Right, that's one of the big things, and their lack of movement, and now all of a sudden they move, or they don't move correctly, or they move without calling you. All those things. Good.
Ms. Bellinger, I have a question about that.
Yeah.
One of the when in the list I seen steroids. How does that
So what is steroids? What does steroids do?
Decrease your immunity.
Correct. So they decrease swelling systemically, or they can do it at a specific point. But one of the side effects of steroid use, I think that was Rose that just said that, is that it decreases immunity or increases your glucose, which affects wound healing. So in terms of that, then we're talking about wound healing and susceptibility to infection. Does that make sense?
yes, it does.
Yeah. Okay.
Yes.
Okay. Maria Rodriguez, now I miss your voice. I'm sorry, I can't make up.
Yeah, no, I'm letting my group talk.
Her time is up.
Pain, right? Post-op pain. A person's pain is a person's pain, right? Again, let's not forget the assessment. Let's look at the FLAC scale. Maybe they haven't come out of anesthesia yet and they can't tell us about their pain. We can look at the FLAC scale. We can use non-pharmacological interventions. The epidural, does the epidural get taken out right away, or like how does that work in terms of pain management?
I think it would be based off of every individual person, right? Because I know when I saw birth on the first one, they took it out that same day. Like they took it out within probably half an hour.
But sometimes they'll leave it in. It depends on the client. It's very individualized. So they could leave that catheter in for 12 hours or something. Spinal anesthesia will go in and that will run its course. So if you know about when those types of medications are going to wear off, right, then you can have the ketorolac ready, or if they have an opioid order, or if they just have, nowadays there's not even hardly, I don't even see Norco as much as I used to see it. It's all like Tylenol and ketorolac. or acetaminophen and ketorolac. But if you kind of know when that's going to happen, and you'll know because the physician will say, yeah, we took the epidural out, so I know I have 3 to 4 hours, maybe 6 hours for the spinal, 4 to 6 hours, somewhere in that range, maybe longer, depending. We can plan. That's that anticipating, right? Anticipating client needs. Some of you have mentioned that you want to work on that. This is a way to do that. And again, mobility, immobility, right? Due to delayed surgical recovery. Who was it that was with me? They might not even be here, but the nurse was so upset that nobody had gotten the C-section patient up to walk. And it had been like over 12 hours. And that nurse was pissed. So she's like getting the client up and the Foley out and doing all that. So OOB is out of bed, right? And so we want them to ambulate as soon as safely possible, or at least to turn them every 2 hours, or maybe get them sitting up, or at least walk to the, transfer them to a chair so that they're changing positions. Does that make sense? Yes, no, maybe? Of course it
Yes.
does. Of
Yeah.
course it does.
Yes.
That's easy. That's an easy thing.
Well, I
and
have a question. Sorry, like,
Yeah.
after anesthesia, getting them up to walk, is there like a protocol of like the time frame, to give them at least an hour post anesthesia to make sure? Because you can ask the patient, but they may say, I
Mhm.
feel fine, and
Right. And so what does that depend on then? What does getting them up out of bed, what information do you need to know?
Assessing the mobility, maybe?
But you also need to know what type of anesthesia they received. Because if they had an epidural, I can't get them up, or spinal, I can't get them up an hour after surgery. That's not going to work. Now, if they got what's called like a pudendal block, where it's like lidocaine, like right into the perineal area, that's going to wear off. That's like a really localized block right there, and they'll be able to get up sooner. But one of the things that how do you get a client up out of bed? What's that process look like?
Dangle.
So, but what do you do before you even dangle them?
Sit them up.
Them up.
Well, if it's, I don't know if I'm thinking too hard, but like if it's an extensive surgery, shouldn't there be an order from PT? Or am I thinking too hard?
So depending, yes, there would be, but PT is only going to do so much, right? Depending, like say it's a knee surgery, for example, they did like a knee replacement. So yes, there will be an order for physical therapy to come in and do an evaluation, and then to get them, what I want to say, like using it a certain, doing certain exercises or something. Now, it may be that there's an order they want PT to look at it first. If it's a knee, for example. But if it's, say, a C-section or an appendectomy, because we see a lot of appendectomies in pediatrics. When am I able to like sit them up or do what to get them up out of bed?
After you ruled out that they don't have orthostatic hypotension.
Right. So I'm going to sit them up. I'm going to take their blood pressure. Right. And then I'm going to have them dangle, right? Turn to the side and dangle their legs. Right. And then what do I have them do? After they dangle their legs, then what do we do?
Come closer and put the feet down.
And have them
Stand up.
stand up.
Hold you.
Do they do anything, or they just stand up?
They hold you.
They hold you
Hold.
for dear life. Right? But they just stand. And then we don't necessarily have to take their blood pressure again, but we ask them. We don't say, do you feel dizzy? We say, tell me how you feel. Oh, the room is spinning. Okay, let's sit back down on the bed. Right? That kind of thing. If they say, I feel okay. I don't feel dizzy. I feel okay. Then what do we have them do before we have them start walking? You actually have them march in place for a couple steps to see if that changes anything. And then we can have them take a step or two, and we are with them to make sure that everything seems to be all right. If they say, uh-oh, I feel unsteady, what do we do?
We sit them back down.
Hopefully we're close to a chair or the bed so that we can sit them back down, or at least try to get them there. Sometimes you'll see in long-term care, we'd see PT walking and they'd have the wheelchair behind the client, right? So if they got dizzy or something tired, they could sit right back in the wheelchair, right? But if you're nowhere near, like if you're halfway to the bathroom and there's nothing around, what do?
Safely let them fall to the floor.
You
If-
fall with them, you safely guide them down
Mhm.
and call for help. Yep. Protecting their head, right? Protecting the surgical site, hopefully. But we do want to get them moving because that's what's going to help. And there's generally protocols, I will say, because somebody was asking about PT, or, yes, there are usually protocols. And so you just want to know what the protocol is. Surgeons may have different protocols. Some surgeons may want them up at a certain point and others may want it later or sooner. So you would always check with that. But the general idea is to get moving as quickly as possible. Collaborative interventions to prevent post-surgical complications. So, the physicians, what they want you to do, your medications, you just mentioned physical therapy, occupational therapy, care coordination, because post-surgical complications don't just happen within like the first 12 hours. When else can they happen?
At home.
At home, right? And so with care coordination, say we've got the VNA nurse coming, right? Those are things we have to have the care coordination, because if it's over a weekend or a holiday and the nurse can't come for like 4 days, that's a problem, right? Maybe we don't want to discharge them until after the holiday. And then I also put barriers to learning. What have you all seen in the hospital setting in terms of barriers to learning? How could that affect complications?
I think I
Language.
actually saw it with my first patient in the hospital. The first semester she had given birth, and it was a Mexican patient, so they adhere very closely to the cuarentena, which means like complete bed rest. So she was not getting up at all, so this caused a DBT that turned into a PE.
Oy.
Yeah, so that was a client education and cultural kind of.
Mm-hmm. Did somebody had another something to share?
I was saying, I think the big one is language. Like, at least that's what I've seen a lot of at Natividad.
Mm-hmm. In what way?
I think just
Because
kind
we
of
have
hearing.
interpreters, right? Don't we have interpreters?
They do, and I think the interpreters help, but I know some of the students were talking about even if they do speak the language, they might not speak the exact dialect and they don't feel super comfortable.
Mm-hmm. Yeah, Katerina, you ran into that, right? Katerina's like our
Yes.
translator queen here. She's got that down.
It's definitely challenging. And also, how do you reassess the teaching? They can say easily, oh yeah, I understand, yes, but then I have no power to make sure that actually the patient is following instructors. And
Mm-hmm. And then I think to Marie's point, culture plays into that. So many cultures have different ways of doing things, or even if you're not of that culture, maybe you still like to do quarantena. Like maybe that's something that you ascribe to, but that's not your culture, but that's something that you want to do. Like, that's why we have to sort of assess.
I think it goes back to education, like just make sure that you tell them why they need to be getting up when their culture has always told them that they need complete bed rest.
Mm-hmm.
Yeah.
And then like moving on to number 5, like dietary restrictions, post-op prep. Let's take that first. NPO. NPO meaning what? And
Nothing
when?
like that.
mouth.
Yeah, nothing by mouth, nothing for oral. And 12 hours, 24 hours, 6 hours, like what's the time frame on that?
I feel like depends on a surgery, and
Mhm.
usually like 12 hours, but maybe
Well, it
24.
On the book, it said like 6 to 8 hours.
6 to 8 hours. Iggy says 6 to 8 hours.
So I have actually seen that change. So I remember when it was like 12 hours, like everybody was NPO after midnight. Didn't matter that your surgery was 2 p.m. the next day. And kids, they'd make kids NPO after midnight. And usually kids are first on the surgery schedule, but even still that might not be till 10 or 11. And that's way too long to go without eating. So I've seen shorter and shorter time spans, even C-sections, right? A mom is in labor, didn't realize she was in labor. She's a previous C-section, but they just went out to Taco Bell, right? And so we can't do the surgery right now because why can't we do surgery if they just ate?
Risk for aspiration.
Risk for aspiration, right? So we have to wait 3 hours, sometimes 2 hours if it's emergent, depending on how fast the person's progressing. But that can become a problem. So it's really important to make sure that the person is honest about the last, because that's one of the pre-op questions. When was the last time you ate or drank anything? Right? And then you also need to get clarification. They should get clarification from the doctor on what medications can they take in the morning before surgery, right? Do they need to take their beta blocker? Do they need to take their diuretic? I don't know, probably maybe not. Do they need their insulin? I don't know. Are they eating? Probably don't need their insulin, right? There's just things to like think about. What about bowel cleanse, bowel prep? Anybody ever drink that disgusting stuff? No?
Yes, it's not fun.
Yeah, have fun. Yeah, I had my colonoscopy. That was not fun. Although apparently the way they make it now, you don't have to drink quite as much. Like we used to have like these gallon things that go lightly that you'd have to like drink and drink and drink to clear out till you were having a bowel movement that was like water.
I heard that was the only thing you can drink as well. It was just that. No food, no nothing else.
Yep. You got it.
You can't do like an enema?
It won't clean out the bowel. It'll only clean a certain part of the bowel, not the whole intestine system.
That was your enema, Arthur.
You know, education on any pre-op medications. That usually happens in the pre-op area. Teaching them incentive spirometry and that, how to splint coughing beforehand, right? Like I think always letting people know what to expect is a good thing, that they're gonna have to ambulate. And then like after surgery, right? We talked about ambulation, the incentive spirometer at that point, and then advance the diet as tolerated, right? So they may, so do you know what advanced diet as tolerated means? Like how you go through that?
Yeah, like go from full liquid to what's next, like chopped or something like that. And
so
then
usually, clears, and then full liquid, and then maybe soft.
soft, yeah.
Depending, some people go straight to regular diet. It just depends on the surgery and the surgeon. And then discharge planning, including teaching. We talked already a lot about the teaching. Things that you did last semester, that home and safety assessment, right? What is their support system? Can they get and pay for medications? Any follow-up visits, right? Do they know how to take care of their surgical site and how to prevent infection? What's the best way to prevent infection?
Washing your hands.
Hand washing. Yep. And when to call the doctor so that they know when to call the doctor. Yeah, so chapter 9 is really good. It encompasses all 3 of these older chapters in the previous edition of IGGI. If we look at the National Patient Safety Goals for 2023, I don't know if anybody knows off the top of their head, but it's like identifying the patients correctly, right? Getting results. Whoa. Using the medications, right? And infection prevention. Here we go. Prevent mistakes in surgery. That's what I was looking for, right? So there's actually national patient safety goals that have to do with surgery, that the correct surgery is done on the correct patient and at the correct place on the patient's body. I think we had a question about who marks the place. I always let the surgeon do it. I'm not doing the surgery, right? So, but that's because people got the wrong leg amputated, which is terrible to think about. mark the correct place on the body where the surgery is to be done, pause before the surgery to make sure a mistake is not being made. Do you know what that's called?
Timeout.
A
Timeout.
timeout, right? Anybody seen a timeout?
I
Yeah.
have.
What's that like?
Everyone just stop and then they just talk about the patient, like identify the patient, date of birth, what they're doing, and yeah.
Like everything stops. Okay, I'm doing a timeout now. I mean, literally stops. Okay, this is this patient. Check the ID band. You know, we're doing this surgery. It's a little different when it's a C-section because that's pretty much the same place all the time. But you know, we're doing a right hip replacement, so then we all want to make sure that the right hip is marked, and then that's what we're doing.
Question about that.
Yeah.
I know that when we went to DI, most patients are under moderate sedation, so they're awake during the timeout. So I noticed that the physician would do the timeout and then verify with the patient just to make sure. Is that something that's like tried to be done, or like
Yeah, I
not
think
just
so. Yeah.
moderate sedation, but for just any general procedure that you're having?
I think what they'll do, I don't know, Arthur, who was in a C-section? Arthur, did they ask the patient their name and why they were there?
I wasn't at the beginning of that
Oh.
C-section. I've only seen the timeout in DI.
Oh, okay. And so that they were asking the patient?
They didn't really. The patient that I had was pretty out of it. Like she did answer like, oh, like, hey, how are you doing? Like, just can you confirm your name and date of birth? Like those things, but not really part of the timeout.
Okay. What, anybody else been to a C-section?
Yeah, when I watched the C-section, they actually had the surgeon call out the timeout. Like they waited on his approval to complete the whole thing. Literally, they waited for him to just from beginning to the end because they got interrupted. So then because something was not working, and then they kind of didn't want to start until the surgeon actually said, yeah, we're good.
Gotcha. And did they
And
ask
they
the
didn't.
patient or no?
No, they did not.
I mean, I think you can ask the patient, but you also have their wristband. But you can ask them. I think as long as everybody knows that this is the right patient and this is the right surgery and this is the right place for doing the surgery, then you should be good to go. I don't think it's wrong to ask the client, tell me your name and date of birth. I would check again with the facility and see what the facilities, either what the facility policy was or what their usual practice is for that. Me personally, I like to include the patient, but or the client.
It sounded like that the surgeon liked to include all his patients to whatever.
Which I think is great.
Yeah.
That's good. You have team steps, different videos about surgical teams checking back in, handoff, and again, SBAR type examples, which are there. And then you have the activity. It's not worth points, but it's nice, I think, to at least go in. I think, Katerina, I think you did it.
Yeah.
What did you think of it?
No, it was
When you
pretty
were starting?
straightforward. It was nice to just look what different parts we need to include in the actual report and what's consisted of. So yeah, it's pretty easy. I mean, straightforward in EHR.
Okay. And even the care plan, I think, I mean, pain. I think everybody was doing pain that I looked at. And you just add, and then I go back and check it. And then you also, for anybody that wants to be involved in surgical nursing, perioperative nursing, you've got the AORN, which is Association of Perioperative Registered Nurses, also the American Pediatric Surgical Nurse Association. So there's some resources there if that's something that you're interested in pursuing. And that's pretty much, so I would focus on, factors that place a client at risk for complications, any labs, like how you would recognize a post-op complication. Those are pretty much the main things. And then I told you for pharmacology, it's the escape room, and it'll be those things that are on that list. And then for exam 1, I will put out by Thursday a list of at least my objectives that will match with the question distribution. So the question distribution is available in week 7. So I know there were a couple students that had that wanted to know if they could ask questions tonight. I'm just not prepared to do that right now, and I wanted to focus on the week 6 things. So you do have in the week 7 module, you have the question distribution, and Ms. Clark and I talked, and students that have accommodations can start at 10, and we'll notify DSPS, and you can notify them as well that you can start at 10. That way, if you're in success, you'd be able to come to success after when we do exam review. But it basically tells you how many questions, how many points, and I think the way that we're going to order the questions is that we'll do my stuff first, and then we'll put the OB, Ms. Clark's things at the end, because she's got the that next gen case study question that she has for problems in pregnancy. And so I think that way you're not flipping back between med-surg ped stuff and OB stuff. Does that make sense? Do you think that would be helpful to do like my stuff and then the OB stuff?
Yeah, that makes sense to me at least.
So at least you're not flipping back information, right? Once you get to the pregnancy stuff, once you get to prenatal care, you're going through the pregnancy, prenatal, and
Yeah, that makes sense.
makes sense. So I think that's how we're going to set the questions up that way. I don't know if Ms. Clark's going to post objectives. I'm pretty sure she'll just tell you to look at the objectives, but whatever she's the case studies, I think bring home the main key points. And then, like I said, I'll have, because I feel like my stuff's kind of more all over the place. It doesn't really follow a pattern. So I will put some focused objectives for you.
Thank you. Can I ask one question? I know you said you're not prepared. I'm just curious about having success right after. So will we have our exam scores right after?
Potentially, because there aren't any at this point short answer questions. They're all drop down, multiple choice, ones that we don't necessarily have to hand grade.
Okay.
And so I think it provides an opportunity, Ms. Clark and I have talked, I think it provides an opportunity for students, if you have questions at that point in time or notice a discrepancy or something, it allows us to address it at that point in time. We may not have an direct answer for you at that point in time, but at least we can, make a note, and we'll be going through it as well. And it hopefully isn't going to take 11, 12, we should have some time between when everybody's done taking it and when we have success, because we look at the results pretty quickly, and we actually look at in real time, because we can pick up on a question right away that either we rekeyed, because the statistics will show us that more students are missing that question, and so we'll go back and look and see why we think, and if so, those will pop up for us pretty quickly. But we feel like giving or providing an opportunity for the immediate feedback, because you'll remember what your thought process was, is going to be more helpful for you.
Okay, that makes sense.
What else? What else can I help with?
I have a question about discharging from PACU. I
Mhm.
see that some of the criteria, it mentions the already scoring and stuff like that. Is that something we should be worried about? Thank you.
Honestly, I couldn't even tell you what that was. That's not what we're not teaching to be PACU nurses. It might be if it's in some review class, they tell you need to know that. I'm sure it has to do, I don't even know what it has to do with, but how stable they are to come out of PACU. But it depends. Are they going home? Are they going to cardiac? Where, what unit, where are they being discharged? But that's too specific.
Okay, thank you.
Miss Sully, so you said focus on the factors of, I'm talking about the quiz again, factors, risk for complications, labs, and how to recognize the post-op complications. So is that going to, so I know like half of the exam or half of the quiz is for you, like your material. So am I missing something, or is there like 2 questions for one of?
Oh, I see what you're asking. See how you are? I don't know. I'm not sharing my screen, correct?
No.
Okay. One moment, please, while I think about that question.
I'll hold.
Right, we talked about SCDs. So yeah, that's, yeah, should be good to go.
Are we having any SARAs? Probably.
One moment. Let me think about that again.
I like how you worded that, Maria, heading our way.
I see one for care of the surgical client,
Okay, got it. Thank you.
and it's not anything we haven't already talked about tonight. Not that that
Well,
helps, but
We talked about a lot of things, but yeah. that helps.
but yeah, but like go by those objectives, right? With the information that I have there, that will help you. What else am I thinking? So one of the post-op complications, we talked about dehiscence and evisceration, but like, what do you do if it eviscerates, or what do you do if you see bleeding?
Well, what if
Post-op.
you try to, like, if able to, like, call somebody right away, but also have the patient hold pressure to it, or you can help hold pressure so that it eviscerate any further?
Yeah.
And I feel like they need to like put the knees up and kind of, if you like, for example, if it's a stomach bleeding and I don't
So
know, I
if
just
there's,
remember
so if
some.
bleeding would be different. I mean, let me try this again. If it dehisces, right? If the wound edges are starting to come apart, or the stitches are starting to come out, what would you do?
Put sterile gauze and call for help.
Yeah, you're gonna call for help and just try and keep as best you can together, or have them be still or whatever, so that they're not.
Don't reinsert the organs that are protruding.
Yeah, you don't want, so for evisceration, you actually don't want to reinsert. You want to just leave it and hopefully keep more, like Maria was saying, more from coming out, right? If you had sterile gauze with saline or something to keep it moist, that would be great, but you probably don't. Even gloves while you're waiting for sterile gloves, something so that the rest doesn't keep coming out is good. And then that would be different from plain old bleeding. What would you do if there's bleeding from an incision?
Try to stop the bleeding, pressure on it.
Yeah, right. And then same thing, what about if there's like all of a sudden a bunch of drainage coming out of the incision?
Reinforce it.
Yeah, maybe some pressure and reinforce it, call the doctor or call somebody, call for help. Yeah, on all of those. What else? Do we at least take the stress down a little bit?
Yeah.
I mean, a little bit, not a lot.
Yes.
Okay.
Yes.
And again, I apologize for the delay, but we were having quite the conversation, and when you're eating with the dean and the guest, I didn't feel like I could leave yet. So I appreciate your patience. And then as soon as the recording is ready, I will post it. I think an announcement works okay, right? I can attach it to the same announcement that had the Sully Sesh information in it. Will that work?
Yes.
Yeah.
Yes, thank you.
You're welcome.
Good night. Thank you.
All righty, get some sleep.
Safe. See you bright and early.
Yes.
Good.
Right.
Thank you. See you in the morning.
Try not to
Alrighty.
miss me too much tomorrow.
I'll try. I don't know if I.
Thank you. Appreciate it.
Thank you.
Thank you so much.
Bye-bye. Good night.
You're welcome.
Be safe.